Ladies and gentlemen, distinguished guests, faculty and students, welcome. My name is Ali Eskandarian, and I'm the Dean of the Virginia Science and Technology Campus and the College of Professional Studies. Thank you for being here. Let me, before going any further, introduce a couple of distinguished guests here. We are delighted to have Lori Lerman, Mrs. Lerman, who's sitting here. She is our provost's boss. And
I'm so glad I came.
she didn't want to be introduced, but you know, my boss is the most intelligent and the most attractive man in the world, so I had to pay my respects. Thank you for being here. In addition to being here in the ways that she has supported both this campus and the School of Nursing, we are grateful for all of your support, Lori, and Steve, of course, who's been terrific. I would also like to recognize Pete Veldy, who's a member of our advisory council, who guides us and assists us whenever we need them. Thank you so much for being here, and I appreciate your being here. It's my pleasure to welcome you to another one of our events in the Dean Series, Dean Speaker Series at this campus. The Speaker Series is supposed to bring leaders and experts together with students, faculty, alumni, and the community, members of our community, to facilitate discussions on challenges and opportunities that face our global society. It's also my distinct pleasure to co-host this particular event with GW School of Nursing and one of my most favorite colleagues, Dean Gene Johnson. And since you guys were all late coming in here, I'm going to have to cut my comments short. The discussion tonight will focus on big data. It's an area that we are focusing on in terms of developing research and capabilities here on this campus, as well as at GW writ large. But we want to investigate the effect of big data, in particular the impact of big data and data analysis on the quality of healthcare and healthcare delivery in our nation. The size and scope of data available now and in the future through electronic medical records is almost unfathomable. In tonight's interactive discussion, we will explore such issues as data systems and data systems management, research opportunities, and the impact of big data and data collection on the patient and provider relationship. So let me tell you a little bit about the two people you'll be hearing most about. Dean Johnson, Gene Johnson, as I told you, is Dean and Professor of the School of Nursing at George Washington University. She provided leadership in the establishment of the School of Nursing by the Board of Trustees in May 2010. So you can see that the School of Nursing is a new entity, the youngest school and college. And it wouldn't have come about were it not for her fantastic efforts to bring it into fruition. So she's the founding dean of the School of Nursing and has led the School of Nursing to a ranking among the top 50 nursing schools. The MSN program was just ranked number 4 in the nation, so kudos to you and your colleagues, or a lot of them are here. And throughout her career, Dr. Johnson has been committed to improving the health and well-being of people and communities, and has designed and launched a range of programs to improve access to nursing education and healthcare in rural and underserved communities, including a Robert Wood Johnson $20 million national program to take primary care education into underserved areas nationwide. And I was present to see her operate and get things done with respect to having articulation agreements with the community colleges, and it's really tremendous the kind of work that Dean Johnson and her colleagues have done in this area. She has been involved extensively in national leadership around legislative and regulatory policy focusing on nursing issues, particularly in the areas of patient safety, quality care, nursing education. So our guest speaker is Judy Murphy, who's the Deputy National Coordinator for Programs and Policy at the Office of the National Coordinator for Health IT, Department of Health and Human Services in Washington, D.C. She's a registered nurse, so she knows what she's talking about. Ms. Murphy joined ONC in December of 2011 after over 25 years of health informatics experience at Aurora Healthcare, an integrated delivery system in Wisconsin. She has published extensively and lectured nationally and internationally on system implementation methodologies, health IT project management, and automated clinical documentation, as well as the use of technology to support evidence-based practice. She received the 2006 HIMSS Nursing Informatics Leadership Award, was named one of the 20 people who make healthcare better in 2007 by Health Leaders magazine, and was selected as one of 33 nursing informatics pioneers to participate in the Nursing Informatics History Project, sponsored by several four-letter institutions. A few of them have fewer letters. AMIA, NLM, AAN, and RWJF. Ms. Murphy is known for her patient advocacy and patient-centric point of view. So we are in for a treat. I can't wait to be sitting there and listening to this conversation and discussion of experts, intellectual leaders in the nation, indeed. So thank you very much. Let's give them a big hand. Worthy of big data.
We thought that we would have, sort of a question-answer kind of discussion tonight because, number one, I think it's quite honestly a lot more fun, than having to have someone, put together a talk and, kind of talk at people. And Judy was really very interested in this format. And I have some questions that I'm going to start off with, but I'm hoping that as we kind of move through the discussion, that everybody has a question that they would really like to have answered because, it is not very often that we have someone with the expertise that Dr. Murphy brings to us around health information technology. And this is such an important area in terms of healthcare and actually other, professional areas. So I'm hoping that you all will be thinking about, have another sip of wine and, think about the questions that you want to ask. So thought I would start out with something that I had actually wondered about for a long time, and it's a fairly straightforward, I think, question. And how did ONC kind of get ONC? Because, you kind of go, the Office of the National Coordinator, where did that come from? If you can share a little bit of that history with us, that would be terrific.
So this is a great story that I could probably talk for the whole hour on, but I won't. The Office of the National Coordinator for Health IT was the original name of the agency that I work for. And you could write out that as an acronym, but let's just say when it's pronounced, it's ONCHIT. and so there's some obvious problems with that. And that was 2004, actually. So we're turning 10 years old this year. And so after about a year of having people say that out loud, it became obvious that it sort of needed to change. So if you go back in literature in the 2004-2005 area, you will see ONCHIT in the literature. And we dropped the HIT part of it, and now we're just referred to as ONC. And ONC, because it's only 3 letters, people generally say. Every now and then you'll have somebody refer to us as ONC, which of course isn't as bad as ONCHIT, but it has its own issues. So same agency, nothing's changed other than the acronym. Now, a big part of our job is coordinating, and we actually use that term a fair amount. And what I mean by that is we say we're coordinating. We're a coordinators, we're conveners, we're catalysts. We don't have a really big budget, so we're not like CMS as a huge agency. A lot of what we do is through volunteer work of the industry, the health information technology industry. And we work hand in glove with a lot of the different organizations. And those of you who are familiar, organizations like HIMSS, the Health Information Management System Society, AMIA, the American Medical Informatics Association. These are folks that help us get our job done.
That's great. It also might be useful to talk a little bit about what health information technology encompasses, because we hear all kinds of terminology: health informatics, nursing informatics, information technology. I mean, there's a lot of terms out there, informaticists. Can you help us make sense out of those terms?
Sure. So health information technology usually references the computers and the devices and the applications that we use within healthcare. So it could be everything from a mobile application used to look up backgrounds on drug information while you're prescribing, right on through the big electronic health records that are installed in our clinics and hospitals today. The definition has really expanded even more just over the last couple of years. I'm going to do another joke. So there's an app for that, right? And there's an app for everything now. And some of the new apps on the market are actually health-related apps. Not healthcare-related apps, but health-related apps. So tracking your steps, tracking your activity and your sleep, tracking your caloric intake, God help you. The kinds of things that give you a sense of yourself as a being. And those are, the quantified self. Has anybody heard of the quantified self? That's a whole movement of using computers to really understand your interaction with your environment. So that's kind of at one end of the spectrum, and then of course the Fitbit's probably at the other end. But there's a bunch of applications now that are supporting consumers as they live their everyday lives to stay healthy. And the crossover between what traditional health IT would have been and these new apps are actually disease management applications. So again, if you're a diabetic and you need to be remembered to check your sugar, or you want your sugars tracked over time, there's applications for all of that too. So self-management of diseases is another huge area. But anyway, bottom line, all of that is health IT. It's using technology in some way, means, or form for health or health care. And it's kind of paralleled, actually, the changes that have been happening in the healthcare industry, right? The healthcare industry has become more and more about health and wellness, and not just about illness care, correct? So this application development and the definition of health IT has expanded along with that. Now, the people who work in this space have all sorts of names, depending on whether you're the person who is having the electronic health record implemented for, or you're the one doing the implementation. That's another joke. They get called different kinds of names. How many people here have done implementations? A few? Goes really smooth, right? Not so much all the time. And so sometimes, there are certain things that happen there. But the people usually who are helping, they could be called informaticists. They could be called informaticians. They could be called informatics specialists. They could be called implementers. They could be called clinical people who are helping. They're all pretty much in that same category. And what changes sometimes is whether you've got formal education or not. Because this is a newer industry, a lot of the folks who are working in organizations in some of these roles actually don't have any formal training. Not uncommon to have been the person who kind of raised their hand and said, I'll help put together training materials. You touch it, you own it, and you're informatics from that moment on, even if you've had no formal informatics training. In the informatics training space, we've got anything and everything from what might be considered more of a training program at a community college, or a little 6-month maybe certificate program, right on through master's and doctoral programs in that informatics space. The programs vary. They vary on how much emphasis is on the technology versus how much emphasis is actually on the application of the technology. You might hear the term bioinformatics. That generally refers to those that are more about the technology and more on the bench side of the bench to bedside continuum. Because again, if you think about research in this area, you would of course be doing some research to apply at the bedside, but just like in any other area of healthcare, we often want to do research right at the bedside too. So when you hear these terms, they're more colloquialisms than anything. You would have to dive down to find out the person who's using the term, what they mean by it, because there's no really big accepted definitions and no terms. Nurses like to be called nursing informaticists or nursing informaticians. Doctors like to be called medical informaticists or medical informaticians. And that may or may not mean the same thing other than the fact that they're a nurse or a doctor by original background. And pharmacists and dietitians and lab techs and pathologists are all getting into this space as well.
So I hope that really makes it clear, about what we're all talking about. It might be useful to give folks kind of an idea of what the work of the Office of the National Coordinator is, so that they understand, how actually complex and what you think about every day.
Sure. So as I mentioned, we were born in 2004 with only an appropriated budget and not a lot of what I'll say extra money for research or for grants to do activities in the field. And it was spawned actually through executive order by see, I'm in that medical thing, by President Bush. And he basically quite famously said an electronic health record for every U.S. citizen by the year 2014. So he was predicting in 2004 when he took office that within 10 years everybody would have an electronic health record. We're coming close. It's not going to be done and done. But I love this issue because it's definitely bipartisan. At least I make it bipartisan. Because when President Obama took office in 2009, he rejuvenated this all by saying an electronic health record for every American by the year 2014. And again, math major is not required. They were agreeing on that 2014 date. He actually said within 5 years, I did the math. But to make a long story short, what changed in 2009 with President Obama was the American Recovery and Reinvestment Act. And at that point, a lot of money was infused into this space, and it was in two areas. The first was to the Office of the National Coordinator to create programs that would support the implementation and adoption of electronic health records in our clinics and in our hospitals. And the second was, and that was about $2 billion. The second was somewhere around $22 billion, and it all depends on who all goes after the money, but about $22 billion to Medicare and Medicaid in terms of additional reimbursements, if you will, bonus payments to providers in hospitals who adopt medical records. The program, again, was kicked off in 2009. The first payments were made in 2011 because the program had to be put in place in terms of meaningful use. Now, hopefully, most of you have heard of the term meaningful use. Again, hopefully in a very positive way. Not always. Because, some people are looking at it because we had to define criteria, and that's what the Office of the National Coordinator helped to do, is using federal advisory committees, actually defined the criteria that would identify whether you were using an electronic health record meaningfully, which would make you a meaningful user, which would allow you to get the payment. So you couldn't just implement an electronic health record, you actually had to use it meaningfully. And in truth, the measure that has been caused the most consternation at the initial start of the program was computerized provider order entry. Because that was mandated. You had to be doing that at a percent level or you wouldn't get the payment as either an individual provider or as a hospital. So what ONC does every day is support this concept of helping the industry adopt electronic health records and use them in a meaningful way. And that gets us to this big data idea, because once you have electronic health records in, you have the ability to collect electronic information, share it, amalgamate it, analyze it, study it, evaluate it, do research on it, and hopefully shorten the circle of how we learn about what works and what doesn't work in healthcare. Okay, and that's why this is so powerful. I'm old enough, and hopefully some of you too, to have been seen most of my life with a paper medical record. And I can say even when I go to the same doctor, they don't always have even the paper in front of them, right? The statistic on that in the 2004, 5, 6 range was 20% of the time patients got seen without their records. Because it was too hard to find it or pull it or whatever. Now imagine if they were relying on your memory or what you could tell them about your history in terms of your continuity of care. And so another big, not just quality issue, but a big safety issue. I oftentimes use my mother, who's now 88, as an example of this in 2 ways. The first way is she's on 14 medications, and there's no way she would remember them if my sister and I would not constantly be keeping track, making copies of her list and putting it in her purse, in her wallet, in her home, and sending it to her doctor, right? And now she's to the point where we always send somebody with her to her visits, because that's how we still create some level of continuity of care. But the other thing that happens is, the doctor says it and she thinks she has to do it. So I mentioned she was 88. About a year ago, she got it's time for you to have your Procto. And I'm like, what? And she said, well, I got the card from the doctor. And you're like, yeah, but Mom, let's just say you had that. Let's just say they found cancer. Are you going to have surgery? And she goes, well, no. And I'm like, then why would you have that? And, a conversation with the physician, of course, changes that. So that kind of thing where all the information is always in front of any provider that is seeing a particular patient is going to be really, really, really helpful.
So every day is an adventure.
Every day is an adventure.
You have been very involved in technology, but also with a view of patient engagement and patient-centered care, which is something that clearly people in healthcare are talking about every day. Can you talk a little bit about, sort of the why patient engagement from your perspective and how technology can actually facilitate it or create barriers?
So patient engagement to me is, other people have said this, blockbuster drug of this century, meaning that it's probably going to be more impactful than any other drug therapy that's going to get created. And the reasons are multifaceted, but lots of research has been done to show that an engaged patient or an activated patient does in fact make a difference. Not just to passing on the information that, like I was talking about a minute ago, that didn't get passed on because there isn't an electronic health record, but also because of things like compliance and understanding their care and buying into their care. So many of you are probably familiar, people get prescriptions and they don't get them filled, right? People are told to do X and Y and they don't do those things. We all know about certain things we shouldn't be doing, whether it's related to eating or drinking or smoking, right? But for some reason, and I put myself in this category, this becomes my doctor's problem. Somehow, you sort of like worry about your weight the day before you're going to the doctor, which of course doesn't help anybody at all, right? So how do you actually change that? Is by getting engaged and taking responsibility and accountability yourself. So as I mentioned earlier, the whole industry is changing, right? Health and healthcare industry is changing. How we think about it is changing, and therefore the patient engagement part. Now, why technology? For me, technology is the hook, right? So everybody's using technology in all of their aspects of their life. So now we say to a patient, you can pay your bill online. You can make an appointment online. You can look at your lab results online. Okay, so they maybe start doing some of that stuff they do in other aspects of their lives, pay their credit card or make an appointment for whatever else. Interestingly, we've found that once you have information, you get a little bit more motivated, right? Now you get motivated to do something with that information. And so in the Office of the National Coordinator, we think about this as data access is the pathway to action. And so once you're starting to look at your lab data, you're like, I don't totally understand what that is, so I'm going to find out more about it. And that's where the accountability starts to shift. And you start to see what a big part you can be of that. And again, is it for everybody? No. My mother, well, actually, she is kind of activated in her own way. I have to tell one more story because this just happened more than a couple weeks ago. It's probably a month ago now. She called me up and told me they were doing something new for diabetes. I said, really? What are they doing? She goes, they're checking your feet. I know. Now, as a nurse for many years, I was happy and horrified at the same time. The happy part of me is, well, at least they're checking her feet. The horrified part was, they haven't been checking her feet. But she took accountability to think about that and to tell me about it, right? And so even in her own small way, she's more activated. And so anyway, bottom line is I get excited about these kinds of things because I think this is our new horizon. And we have the whole gamut of consumers. And I don't know, how many people have heard of ePatient Dave? A few. So ePatient Dave is way on this end of the spectrum. He writes songs and is all over YouTube on "Give me my damn data." So he's a patient, and he is super activated. And on behalf of all the other patients who aren't saying anything, he is out there as an activist. And for him, because he had errors in his medical record and he was able to correct them. This is, a journey for him, and he is going to make sure that that doesn't happen to anybody else. And as a result of being activated, he actually found some cancer treatments and got involved in some cancer protocols that he wouldn't have found through traditional therapy. And then, everything up to this other side where, we've got the person who, maybe asks questions and maybe doesn't. And in the middle, we've got the people who, are thinking about, I might want to get a second opinion, or, gee, I'm a partner in this. I want to do some shared decision making with my provider. And I think we're going to continue to see a gamut. I think as those of you who are healthcare providers, particularly the nurses, I think this is something that we own, making sure consumers know about. And what I say to everybody is the best way to be able to share and talk about it with patients is to do it yourself. So if you don't have a personal health record, if you're not signed up for the portal, if you're not looking at your own lab data, do it. I think it's a great way to get some experience, and it gives you a background so that you can talk about it with other patients and the folks that you interact with. If you're not a healthcare provider, do it anyway, because you're at cocktail parties and you're at happy hours, and you can share your experiences. And this is going to be a groundswell effort, I think, but it's probably going to be the thing that's going to change healthcare more than anything else.
One of the things that I actually can say, we were talking a little bit about Fitbits, just kind of joking about, so are you going to walk over here from innovation or not and get your steps in? I have to say, personally, and from what I've seen from other people's behavior, you get a Fitbit, you get, or whatever the information, the technology may be, that you get information back about what you're doing, and suddenly it becomes really important. I mean, my husband and I'll we'll be, kind of doing mini steps really fast to get those steps up to get to 10,000, and you go
in their living room while they're watching TV, because they're only at 9,650.
Yeah, exactly. That's exactly the kind of thing that happens. And so, anyway, I think I would agree that is going to be and is a powerful technology. Will be really powerful in changing people's behavior. Mm-hmm. You have. Worked on, the whole notion of health information exchange. And, since we've been talking about patient engagement and patient-centered care, would like you to talk a little bit about, the health information exchange and how that affects patient engagement and patient-centered care. But then also, sort of talk a little bit about how this affects, the delivery system.
So I think we all had a dream 10 years ago that this would be easier than it was. And as I mentioned, just getting the electronic health records in has been a journey, and it hasn't gone always real smooth. You can't exchange data if it's not electronified. So you have to have an electronic health record or some way of collecting the health data first so that then you can exchange it. Okay, so step one, get that in. Now you want to exchange it. The biggest issues that we have with exchanging the data is the standards. We don't have standards. So I'll talk quickly about nursing. So we do respiratory assessments. We do ambulation strategies. We do abdominal assessments and bowel sounds and documentation of what people eat and their intake and their output. And guess what? That goes into the electronic health record in what is essentially non-codified text data. Okay, so think of it as a giant PDF. Now, there's some algorithms you can run across that to turn it into a codification, where it actually reads the text and it says, oh, this said that word, kind of thing. But in truth, that's a huge barrier, because if we are going to truly exchange information, it has to be taken from one electronic health record into another and put into the context of the workflow of that practitioner. So I can pass the information on in a PDF, but where does it sit? Well, it sits in this little application over on this section over here that I have to remember to open up to see if there's any previous history. Where it doesn't sit, if it's lab data or vital sign data, it doesn't sit on the flow sheet where all the other stuff is, because it's not codified, because I'm not sucking it out of one EHR and putting it into the other in a format that it can actually be displayed in conjunction with the currently collected data, because it's a different EHR. So we, the federal government, we have been doing all sorts of work over these 10 years with escalated effort in the last 5 years to try to put standards in place so that we can exchange data and understand it. So don't just bring it in, understand it, and be able to put it in a place that it's actually going to be useful within the workflow of the practitioner. That work is progressing. We've done good jobs in things like problem lists and allergy lists and medication lists. We've not done so good in some of the things that I talked about earlier, assessment data, fall risk information on patients. Even though more people are adopting the standard Braden scale and some of those other scoring scales that we have, everybody doesn't adopt it the same way. We have a rich history as nurses and as physicians, a rich history of individualization and not even agreeing within the same organization. The ICU has to have a different flow sheet than the med-surg unit or the step-down unit. And although that served us when we had our little, narrow silo hat on, it doesn't serve us when we want to exchange information. So those are the technical barriers. Then we actually have some people barriers, and the people barriers, I've been practicing this way for long enough. I'm not going to go looking at, and besides, I don't trust the information collected by that other person, okay? So we, on top of that, have some people barriers. That being said, the essence of a patient-centric record is that it's a patient-centric record, meaning it follows the patient wherever the patient goes, and that data is available to everybody who's caring for that patient. And the concept of patient-centered care, furthermore, is that anybody who's interacting with that patient has the same accountability to look at the information and take action if it's appropriate. So I'm the pharmacist, I'm filling a prescription, and I'm giving it to my mother. I might say to her, I see you're a diabetic. When's the last time your feet were checked? But seriously, right? Seriously. The cardiologist or the endocrinologist and the family practice are all responsible. And if through a patient-centric record, one of those practitioners sees that the patient hasn't been seen for a year, they ask the question, right? Or if it's a female patient asking about the preventative things. When's the last time you had a mammogram? I see in your record, it looks like it was 5 years ago. Not going to get into the guidelines part of it. I see that it was 5 years ago. Have you had one that's maybe not documented in the record? So that's really the concept, is that everybody is taking accountability, which of course feeds directly into where we're going with payment models. Pay for value, pay for performance. Don't pay for activities. Okay, don't pay for tests. Don't pay for, radiology exams. You pay for outcomes. All right? So when you think about things like ACOs, what happens? You have to have a patient-centric record, because everybody's got to be bought into the health of those folks in that community. And again, you can think of there's technical barriers, but there's also people barriers of us agreeing that we're working on the health of a population instead of worrying about our return on investment for our individual organization. So this journey, this revolution has definitely begun. CMS, through many of their payment pilots, value-based payment pilots, particularly ACOs, but also some of the state-based ones through their I don't want to throw acronyms around. They have some state-based grants called SIM, S-I-M. These are the kinds of things that are starting to say, how does this work? And how can we start to change where we're basing payments on outcomes? And again, patient-centered records are going to be key to that. And patient engagement is going to be key to that. Because, how many people have worked on medication reconciliation as a practitioner? It's kind of a pain in the neck, right? I always said to myself, just imagine if the patient helped us, how much easier it would be if they carried their med list, right? Because nobody really wants to do it. Nobody really wants to be accountable for it. The nurses really can't do it. It's supposed to be the doctor. Doctor doesn't want to do it, except the meds they prescribed. There's lots of issues with that. So imagine, again, if it was a team and the patient was part of that team. So to me, patient engagement and the patient-centric record really do go hand in hand. The last part of your question was about what does that mean for something?
Well, it was about accountable care organizations.
Yeah, and we did get there.
Yep.
Yeah.
But now I wanted to follow up because the exchange of information, really requires interoperability of systems. And if you could talk a little bit about where we are with interoperable systems, any models that you know of.
Yeah, so a lot of the exchange was funded, remember that $2 billion I was talking about? So we did seed money through the Office of the National Coordinator to set up exchanges in every state. And they were referred to as the state designated entities. They had to identify health information technology coordinator, and then they had to set up the infrastructure for exchange. So what's happened in some states is that the infrastructure has gotten set up, but because of the people issues, so we got over the technical issues, exchange isn't actually happening. They're too busy doing other things, and again, the money was given to set up the infrastructure, not to incent people to do the exchange. So this next round, we've got a little bit of money left, and our next round is going to be to actually pay for exchange, not pay for the infrastructure, so you actually get the motivation to start doing it. As you can imagine, when something is state-based, there's everything and anything under the sun in different states. Some have advanced very well and have a lot of exchange going, and some have very little. I would say some of our premier sites here on the East Coast, New York. New York is, they not only have our funding, they had some state funds that they used, and they have set up an infrastructure and have care models there that are almost unequaled anywhere in the country. I will say, though, Maryland's done a good job. California's done a good job. In some cases, the value propositions for doing exchange were so strong that they didn't even need our seed money. So Indiana's a good example. Long before we were giving money from the federal government, they had set up exchange and were charging providers for delivery of lab results. And since that was set up 10, 12 years ago, there was a huge value in that for people who had electronic health records, and people would pay a per transaction fee for that. And they moved right from that into immunization and immunization registry access, which was another value proposition where people were able to and interested in paying for. Immunizations is a good example, again, state-based. We have 48 of our states have electronic immunization registries that providers can access. So that's a really positive thing. 2 of the 48 have been opened up to patients. And I smile about that myself because my 30-year-old daughter just moved to Singapore. And what did she need when she was moving? Oh, yes, her immunization records. And I had just moved. And so, luckily, my electronic health record wasn't electronic. But it was a card, like many of you probably have for yourselves or for your children, a card that had all the dates on it, and it was in my phone directory. And when I moved, I don't need my phone directory anymore. All my numbers are in my phone, right? But did I throw out the phone directory? No, because it's my immunization registry. So I kept the phone directory, which had the immunization registry, which I could give to her. And as I did that, I thought, Judy, you are really stupid. You could go online and, like go to a PHR and put this in there, which I subsequently did, by the way. But it's a good example of we just haven't valued this over the years. And think of how many times you have to do your immunizations and give that information. Yeah.
Oh, yeah. That's really an interesting example.
Yeah.
Because that is something I bet that everybody in this room kind of struggles with. Because I can tell you, I don't have mine. And it's always an issue. I keep trying to write it down. Wanted to come back to what you were talking about with electronic health records. And this is something you said while you were talking about the health information exchanges and workflow. Because I wondered if you could talk a little bit about, number one, the state of integrating electronic health records into different health settings, and number two, how it's changing workflow. Because I hear that that's an important issue. Many directors or chief nurses kind of say, it's not so much the information itself, it's how it's changing the workflow. Yeah.
So electronic health record implementation in hospitals is going gangbusters. Our last statistics show that 85% of the hospitals in our country have received stage 1 meaningful use payments, which basically means they not only have it in, they've got computerized provider order entry going on. That number is not as good in the provider space, meaning the clinics and the individual small practitioners, in some cases, many cases. There, the statistic is only 50%. Now, the American Medical Association funds a study, and they're showing it's a little bit higher than that. Not everybody has gone after the meaningful use payment, so it's more like 60%, 65%. But still, in an era where we live and die by our smartphones, and many of us wouldn't dream of going to a travel agent to book a trip, do a hotel reservation over the phone, make an airline flight reservation over the phone, right? It's odd that healthcare continues to lag, but we do absolutely continue to lag. Now, connecting them to each other is this exchange part and the interoperability part. Huge focus on that. Congress is particularly interested in that because they think that's what we promised back in 2004. And so very important to get those ions moving. Like I said, the infrastructure is in place, but we have to actually start valuing and doing the exchange of information. Last but not least, getting to your question about workflow. So I think that a lot of us thought that getting the electronic health record in was the hard part. Like, let's implement this and we're done and we'll move on, to the next thing. And I think what many of us had found, and I was an implementer for 25 years, getting it in is step one. Getting people to use it and integrate it into their workflow is step 2, 3, and 4. And what I mean by that is it's one thing when you practice the same way you always did, and then you go and do your electronic documentation because it's there now instead of doing it on paper. It's a different thing when you start to think about, well, this is electronic. I can actually integrate it in. So if I'm doing a patient history, I sit down, I take the laptop, and I put it toward the patient, and I show them what I'm entering in. I'm doing a blood pressure on the 5th day of admission, and I want to show the trend of the blood pressures. I turn it, and I show the patient. I engage the patient in that way. I actually integrate it in the way I'm providing care. And that actually gets into the next step, which is I actually maybe change the way I provide care because I'm maximally utilizing the information. So the analogy I like to use here, and this probably doesn't work for the young people, but I know for the old people it does. It's like the difference between moving from a typewriter to word processing. And by the way, my 30-year-old daughter never has done anything other than typed. She could not write cursive today if I paid her. And so, I'm sure it goes, quote unquote, down from there in terms of age. You can do your signature and that's about it. And that's just because of, how things have changed. But it's important to think about when we moved to word processing, it didn't just automate the typing, okay? It actually made it easier to make changes. So it didn't you did drafts in a different way. It started to change the way you thought. It started to change the way you actually, wrote papers and did homework assignments, And then I went to the next thing. Oh my God, different fonts and different styles, and I can change margins. So what happened? You upped your standard in what you expected and what you wanted that document to look like. The same thing is starting to happen in healthcare. Our ability to provide safer and quality care keeps getting better and better because the tools we have are better. We can get reminded about best practice. And I'll throw another statistic out there. A study, this was a couple years ago, 2 years ago, Cleveland Clinic. How often do diabetics get, there's 6 things that are considered best care. And those 6 things are supposed to be done for all diabetics on a pretty much annual basis. A couple of them are more often than that. In this country, when that study was done, 17% of the time, diabetics got best care. And my mother was in there because obviously they weren't checking her feet. And checking your feet is one of the 6. So that's one statistic. Now, the study was actually what happened when you automated that and created reminders and templates and things. It went to a rip-roaring 54%. Triple the 17%. But as a U.S. citizen, are you happy with 54? If you're a diabetic, are you happy getting best care 1 out of every 2 times? No. Yeah, we got to keep demanding more. So that gets me into that, not just have the electronics, not just have the clinical decision support, really thinking about how we're delivering health care and totally revamping the way we think about health and wellness.
Okay, we've talked about engaging patients, patient-centered care, but how do you see technology helping us be more of a team, the interprofessional team? There's so much attention to, people being able to work together, to be learning together. How can technology help us do better with that?
So this is, to me, tied into the things that we were talking about before with patient-centered care and patient engagement, because it brings up things like patient-centered medical home, intercollaboratory practice, all practitioners practicing at the top of their license and doing what makes sense of what they're the best at. So I really do get excited about that. Now, imagine if you didn't have an electronic health record and if you had a team providing care and you had to somehow pass the information between each other on paper. And maybe you're in the same physical location, maybe you're not. Electronifying all this stuff just simply makes the passing of information a lot easier. But you can also have what we've always referred to as care plans, but they can be longitudinal. So practitioner A can send notes to practitioner B and even recommend what the care practice should be that should get implemented in that care plan. And again, those of you who are nurses, we've been doing quote-unquote care plans for a long time, or at least for the week before Joint Commission comes to an individual organization. And I say that really tongue-in-cheek because it was seen as, this is me providing care as a practitioner, and I didn't really integrate the use of care planning into my everyday practice. I really did it kind of as an afterthought. Well, imagine now we have intercollaboratory practice. We've got intercollaboratory care plans where everybody sees what everybody else is doing. And again, you just can't do that without having it be electronic. And so I see the tools and the practice just going hand in hand. You can't do one without the other.
Okay, thank you. I would like to, I've had the benefit of being able to ask questions that I've had, but I would really like to open up to anyone who has questions for Dr. Murphy. Okay.
I wanted to thank you again.
If you could say your name when you ask a question.
Sure. It's Lance Rebels. And my question is, your background, you were involved in a lot of rural type of activities, right? The thing that I'm hearing from some of the tribes, some of the rural areas, is the conductivity issues, right? Mm-hmm. So if we're really going to look at utilizing technology, right, in those areas, don't we have to really somehow address the conductivity issues? And I'd like to see if there's anything that your agency is doing or that you've heard of to try to assist in that.
So did everybody hear the questions about rural and connectivity? And this hits home to me because I built a new home and there is no broadband in my neighborhood. And for those of you who have tried to get high-speed internet through satellite, yeah, you pay by the byte. It's ugly. So we were just talking about this. So critical access hospitals, small practice providers in rural area, a particular concern. So imagine a federal program where we have the haves and the have-nots, right? Where the haves are the ones in the urban areas and in the large academic centers, and they're doing and getting all the money for meaningful use and getting the, money, and the rural areas are not. So right from the beginning, that was not on the agenda. We had to pay attention to rural right from the beginning. Now there's a gap. There's no question. There's a gap between urban and large and rural and small. But our goal was to close the gap or at least not widen it. And we have been successful in doing that. Now, how have we been successful? I've got 2 people in my division. They do nothing but worry about rural. And worrying about rural means thinking about the 1,700 critical access hospitals and which ones have broadband and which ones don't. And today, the number's in the 40s. I don't remember the exact number. It's called 47. There's 47 hospitals in America who do not have broadband. I mean, it's one thing, me and my little subdivision, right? And so getting that connectivity. So the FCC, the FCC and the USDA have grant money available to get broadband in all areas of our country. And so we perked up and said, well, healthcare, that's a big deal. Let's get some of that money. And so we're trying to say to these people, fill out these applications. And of course, they don't have a clue. So what we did is we did a road tour. We took our 2 people and they went around the country and sat down with people in these rural areas and helped them fill out the applications. And in some cases, the applications were to extend broadband. In one case, I mean, I'll never forget this. I got a thank you note from somebody, a provider in a rural area, and it was a picture of an air conditioning unit. They were able to fund an air conditioning unit that got put in a building so that they could install the server for the electronic health record. This is what we're dealing with. I mean, it's a whole different world, and it's not the world I lived in before. I remember doing a couple of tours and going to small rural hospitals, and you're meeting this person and they say, oh, I'm the IT director. And then you find out they're also the director of housekeeping, the director of lab, and the chief nurse, And that's just 4, 5, 6 bed hospitals. That's what they're dealing with, is critical access. So we have paid a lot of attention to that. And I'm happy to say, new statistics just came out last week, and the gap has not widened and it's shrunk a little bit. Indian Health Service in particular, though, we have been working with. They are meaningful use eligible. They're the only federally funded healthcare organization that is. DOD is not, VA is not, but Indian Health Service is. And so we work actually quite closely with them to make sure they're getting their share.
Right. Other questions? Okay.
My name is Pippa Morse. I'm a BSN student in our accelerated program. And my question regarding what you were talking about with the patient-centered healthcare record, we've learned a lot about the patient-centered medical home and the Kaiser apps and the interfaces and all the kind of things that they do. What roles and responsibilities do you think that the health insurance companies should or shouldn't have in kind of developing this health information exchange?
A really, really good question. I think they've got as much accountability as the provider organizations. Now, of course, in the case of Kaiser, it's dual. And I'll actually extend that just a little bit, and then I'll come back to the payer. We're seeing a lot of activity in a lot of areas. Okay, so Walgreens, CVS, they're creating what I would call a mini electronic health record. They're providing access to their patients electronically to the information that they have about them. So in the case of the 2 large ones, CVS and Walgreens, they also have a quick care. Okay, both of them, they call it something different, but urgent care that you can go in and see. So they're pushing the envelope to the traditional provider organizations, right? Because they're kind of, to me, it's like laying down a gauntlet. Well, we can do it, So the provider, I think, are looking to step up. I love all this activity, and I'm particularly happy most recently about Walgreens and CVS because they've agreed to brand their stuff Blue Button, which is something that we've started. But it's commoditizing healthcare. So, I don't know what generation this started with, where it's more of a commodity now. But I know my generation, going to the doctor's a big deal. You put it off, you put it off, you put it off. Then it's this big deal because there isn't going to be parking and I'm going to have to wait. And it's going to be, I don't really like my doctor and I'm going to have to strip down and put that stupid gown on. And every reason under the sun why I don't want to do it. And what things like Walgreens and CVS are doing, they're commoditizing it. You need a physical, you're a college student that needs a sport physical, come on in, we'll do it for $49. You need to be seen because you've got a rash, come in, we'll do it for $79. You can't even find out how much it's going to cost when you go to a traditional provider. So that actually gets me, really, really excited. So transparency to the payer data and integrating gets us back to the big data again. Integrating the payer data with the clinical data is super, super important. And in the short term, maybe that aggregator is the patient. We have some pretty smart patients now they go to 2 different providers and maybe they have a payer. Payer's got some information, provider, they're the amalgamator, okay? So they're taking this information and bringing it down into a place like Health Vault, bringing this information, putting it into Health Vault, bringing this information, and then when they go to see yet a 4th provider, they have the information that they can take on jump drive. So, again, that's why this patient engagement movement is so big. It's going to push the industry because people are going to be starting to expect those kinds of things as well. Payer data is important. It's got a plethora of information. And that's why just within the last week, Medicare agreed they were going to be releasing a bunch more of their information, and they're a huge payer. Did that answer your question?
Yeah. Okay, Lori?
Hi, I'm Lori Luhrmann. I had an experience this week which sadly has become all too familiar. I had a doctor's appointment. I was answering the usual "what brought you here today" questions, and I found myself speaking to the back of my doctor as she sat at the computer and simultaneously read my history, entered my data, and listened to what I was saying all at the same time. If my body language had been screaming, "I'm lying," she never would have known that because she wasn't looking at me at all. And that seems to have almost become the norm in my recent experience.
Yes.
When I got home, I read an article about an emergency room in New York, which is now paying what they're calling medical scribes to follow the doctors around and enter the information so that the doctor can listen to the patient. So my question is, what do you know about that, and what other things do you know of that are trying to work around the barriers that have now been set up by the new technology?
Let's keep in mind the barrier is being set up by your practitioner because of the way that they're using the equipment.
Of course.
Okay? So imagine them sitting in front of you, like maybe we're sitting, and you have an iPad on your lap, or you have a small laptop on your lap, or as I was alluding to earlier, it's here and the screen is so that we can both see it. It can be used as a tool and not as a barrier. That's what some of this workflow stuff we were talking about earlier. It really plays into the type of device that you're using and how that device gets integrated into the activities that you have to have or that you have to execute. It plays into the applications too, because if the application is super keyboard driven, an iPad isn't probably going to do it for you, right? You actually need a full keyboard probably if you have to do a lot of typing. If it's a lot of drop-down listen things, more web-based kind of user interface, it would probably work just fine. So there is a whole movement in this informatics community around what is being referred to as usability. That the usability of an application has to be such that it can be used within the context of a patient encounter in a way that is conducive to the interaction and not a barrier to the interaction. So I think you're right in that. I have also heard stories, and it sometimes has to do with the age of the person. Sometimes it doesn't, because they're struggling with the application, and they may even be under their breath while they're doing, You know, and I've heard stories of that too, because it just got implemented, or maybe they just plain old don't like it. I think that we're reaching a tipping point in understanding this stuff, and we're going to start to see a shift in that. That being the case, I think if you're comfortable, you should speak up. Now, that's a hard thing to say to do, because this is the person that you have to have this good relationship with, right? Because they're your doctor, and you want them to be helpful to you and honest with you and all that kind of stuff. My personal experience is I have a better relationship with the two people I saw at a quick care than I have with my regular doctor. And I know some of that's me. It's just because it's this long established thing, you know? And to be honest, the two people that I saw when I did have to go to a quick care were nurse practitioners. And they knew they had this half hour, in my case, half hour with me. And I'm telling you, you know, my doctor has never had the weight discussion with me, and that nurse practitioner was not going to let me out of that room until she had that conversation. And then, you know, I said, you know, my blood pressure, it's borderline. She looked at me, she said, your blood pressure is not borderline. I am giving you a diagnosis of high blood pressure. That would be a 915, whatever it was. And I mean, she knew that was her only time with me, and she wanted me to change my behavior. You know? And that's how it should be. That was the right thing. I walked out of there, I was so proud of her, I was so proud of nursing, you know? And that's where the pride ended. I wasn't very proud of myself. But I don't know what it's going to take to change that, but it's a partnership, right? It is. And I think, again, we're going to see that evolution. It's not there yet. So what I can say is people are studying it. They're making the applications easier, so it's not like, you know, it's more like, but we've got a ways to go. We have a ways to go.
Okay, we have a question here.
Brian Bisley, I'm an IT at GW. You had mentioned rural areas. What do you do besides dealing with the hospital who may not have the technology when you're dealing with people in rural areas who don't think it's anybody's business to know their information? I lived in Texas for 18 years, and I ran into that all the time. It's like, it's not the damn government's business to know what's wrong with me or things like that. How do you deal with patients like that who will not give you the information because they're afraid somebody's going to?
Totally. So education, of course, is really important. And I know earlier I mentioned probably the best way that you can become a supporter is by doing it yourself, so that you have experiences to share. And that personal touch really does work. They are afraid. Privacy continues to be the number one issue, rural or not, on the part of patients. So I'm familiar with large organizations like Tenet. You know, they have 179 hospitals or something like that around the nation. They rolled out a patient portal. It was an opt-in, and depending on the hospital, it's between 1% and 3% opt-in. Yeah. So I'm not even talking about rural. I mean, I'm just talking about in general, okay? So how do you combat that? Well, you talk about some of the things we've been talking about here. You talk about how it can be different. And it's a culture change. There's, you know, absolutely no question it's a culture change. So it's not going to happen overnight. It's not going to be one encounter, you know, that's going to change it. But we have some public service stuff that we've done. There's many other organizations. The Society for Participatory Medicine is actually a group of doctors and nurses that have gotten together and say, we are going to help move this needle to get patients participating in their care. We are not godlike figures. We need to be partners, and they talk a lot about this, and they've published some things. So if there's a little closed circuit TV system or anything that can be, you know, even if it's just the, you know, plug in the old VCR in a small rural doctor's office, it is that exposure, I think, that's going to change. But it's a culture change, so it's going to be slow.
Yeah. Actually, I'm only going to take two more questions because it's the time has gone faster than I can even imagine. And the hands are going wild. Let me take one here, and then I'm going to give Ali, you know, maybe the last question.
It's fantastic to keep all the data, big data, and everything, keep electronic records. So what is the security aspect? Already, I think insurance companies are dictating a lot to doctors what they should do, what they should prescribe by avoiding costly drugs and a generic discussion. So this information, how much information is available to the insurance companies, and where is the line to draw?
Yeah.
And just one more thing, the security. I understand that this data is being stored at exchanges at state governments or somewhere, I don't know where they are. What is the security process, security protocols to be followed?
Yeah. So first of all, there is no database in the sky that has all this health information or anything like that. There's no central place that it's being amalgamated or put together or anything like that. There are some exchanges in states that hold data, that hold a database of data that gets accessed. Some of the other exchanges do not hold data. They simply route requests for information and bring the information back. So they're more like routers. HIPAA is the major security rule that overcomes or lays over all of this, security and privacy. It's fairly strict. It not only says what you can and cannot release without the patient's permission, but it actually puts onus on the organization to give it to the patient if they want it. And that actually tends to be the one that I talk about more these days, so let me just go there for a second. Meaning, we have patients all the time that tell us, I asked for my health information and the doctor says I can't have it because of HIPAA. And as it turns out, HIPAA says the patient has a right to their information. And furthermore, the HIPAA mods within the last year say that if it is kept electronically, the patient has a right to get it electronically. So that's real clear in terms of the patient's right to that information. But that's the one that has for health data, overseen it all. And it has all sorts of requirements. Everything's got to be encrypted, which is why, people say, why is health data exchange so difficult? Internet's everywhere, it's pervasive. Well, we can't just use internet protocols. So this is like, when you do your credit card and you get the VeriSign or you get I forget all the different little symbols that do that extra security check when you're putting your credit card information in. It's very similar to that kind of thing. It's a special protocol pulling in the information and encrypting it in a unique way. Protected health information, PHI. A lot of rules and regs about that. Now, we all hear that laptop got stolen and it had patient names in it, And so I always thought we were the worst until Target. So, now I'm like, okay. And now it's whoever else, Macy's or Lord & Taylor or whatever the heck it is.
Neiman Marcus.
Neiman Marcus,
Yes.
it's like never ending. So I think that research is going to help us a little bit in this way, but let me just take it a step further. Some of the work that we're doing right now, and it's actually not in my office. There is a chief privacy officer who runs a completely separate office with a staff of 12. They wake up every day. This is all they worry about and think about. In that office, they're talking about data segmentation and the patient's right to data segmentation, meaning that you can take chunks of information and basically say, I don't want this shared. I do want this shared. So it's not just an opt-in, opt-out. It's not just a you can do it, you can't do it. It's going to be further differentiated to I agree to allow it for this data, but not for this data. Okay? And I know that's what people are worried about with employment and, the comforting thought for the moment is that there is no big database where this is all available. I mean, there.
Okay. Ali,
Thank you.
Dean Eskandarian. Yeah.
Dean Eskandarian, thank you very much. I had one comment and a question. The comment is, we just went through this exercise with the new provost when he came on board to develop a strategic plan for the university. And I'm just delighted to hear the conversation here, how enlightened one of the pillars of that vision is, because it prompts us in the university to look into development of cross-disciplinary programs. Those are the types of programs that the next generation of students need in order to be operational. And while listening to Lori's experience and the doctor, I was thinking immediately this is a fantastic example of how several disciplines have to come together for one person's experience. And why can't we use the latest, speech recognition technologies, for example?
Sure.
To record the patient's comments while the doctors look at them where the scribes, of course, are the crudest way of going around with the doctor. So I feel good about our institution actually taking this extra step towards the future. But the question is along the same lines. One of these interdisciplinary fields is, of course, the health IT discipline, and we are in the business of education. So, in your opinion, what kind of talent do we need for the next generation in that arena? Do we need people at the bachelor's level, at the master's level, and if so, what should the emphasis be in these programs?
So I think on that continuum that we were talking about, from bench to bedside, heavier over here, of course, would be the PhD type, actually looking at the science of implementation and helping us see what things really make a difference and what things really work well. Today, what we have for implementation of health IT is anecdotal. I mean, we tell stories to each other, and we learn from each other, but we don't have true good science. So helping with that kind of a science on that research side. For our day-to-day analysis and changing the way we think about our workflow and how we execute on the use of the systems, I love the idea of master's prepared individuals. I think it's perfect. They're schooled in the ideas of what we have to do to provide good health care, and then they're pushed just enough to think about some of the other kinds of changes and stuff that can be made. But as I think I've probably shown, my bias is always toward experience and harnessing the experiences that we have and making sure that we learn from what works and what doesn't work.
Actually, I lied in terms of the last question because
Allow another one.
Yes, Dr. Mary Jean Schumann, when we were talking at before we all got here, had, I think, a really great question that would wrap this up, I think, in an important way in terms of the route.
So for our students who have graduated or who are graduating soon, and young nurses who envision themselves really wanting to engage around big data, informatics, what's that career trajectory look like for them? What's important for them, and how do they go about becoming the next year?
Good luck with that. I consider myself a little unique, but a little odd too. So is everybody else, exactly right. So to me, the idea is, if you were straight out of nursing school, could you or should you go directly into informatics or whatever clinical experience you have? I would tend to want to say no. I would tend to want to say get some clinical experience first. And that's because my bias is toward the health IT person, no matter what you call yourself, okay, the health IT person. The value that you have is by knowing healthcare, okay? And sometimes even a year or two really rounds out your education to the point that you understand the interactions. You know how it works in a hospital or in a clinic and how patients interact with the system. And so getting that as your base before you move into informatics, for me, that would be a huge bias. And then the next thing, and it's something I did in my career, and it happened more by accident for me, you could probably orchestrate it a little bit more, is don't just mind your own business, Start looking a little bit bigger, lifting your head out of your own organization and saying, there's this HIMSS organization, or there's this AMIA organization, or maybe it's a local organization where people are getting together and talking about what they're doing in this space. I'm going to get involved in that. I'm going to start sharing my stories. I'm going to volunteer on a committee. It gives you that broader experience, but it also gives you exposure to everything else that's going on and gives them exposure to you and what you're doing. So then you start to evolve what might be considered to be your career trajectory, right? Because you start to hone in on things. Then getting into a career that has something to do with informatics or doing the additional schooling. And I don't care which comes first. I think there's an advantage to getting the experience and then rounding it out with the education. I think there's something to be said about getting the education and then getting the experience. And people are hiring both. You know, generally people are hiring people who have good attitudes and who understand the space and who are passionate about wanting to make a difference in healthcare through the use of health IT. And so that would be my thought in terms of career trajectory. Yeah.
You know, I think that was a great way, you know, to probably end the program tonight. And I really want to thank everyone for being here. You know, Ali, I don't know if you want to say anything.
I just want to thank you for being here again, and that we have, this is a series, so we have more distinguished speakers coming here. I hope you come and join us. We'll try to feed you again. And our focus here has been on big data and cybersecurity and other aspects that have synthesis and actually relevance to the kind of research that we do here. And so I anticipate we'll have many more events where we will be talking about the confluence of big data, high-performance computing, health sciences, and a lot of it is predicated on the success of our nursing faculty and students here. So we should give them a big hand, and yourselves a big hand for making such a big difference for us here in this area.
And I would just particularly like to thank Dr. Murphy, you know, because we had scheduled this, you know, some months ago, and we all experienced this, you know, really rare event of the closing of the government, you know, and, you know, the government employees were not allowed to do anything really during that time. And so we've been just really, really grateful that Dr. Murphy, you know, was able to come and join us today. And I know I learned a huge amount just in the very brief time that I've been able to talk, you know, with Dr. Murphy. So again, let's thank Dr. Murphy.